Assalamu alaikum. Good afternoon, everyone, and welcome to our academic activity for today. So today we have two lectures. The first one about the pathophysiology and diagnosis of infective endocarditis will be presented by Dr. Ghada Al-Harbi, and the second by Dr. Shadha Al-Mutlaq about guidelines for management of infective endocarditis. So we'll have 5 minutes and we can start. Dr. Ghada?
Yes.
You can start, thank you.
Okay, Assalamu alaikum. How are you, everybody? I'm Dr. Adel Harbi from Medina Cardiac Center. My lecture today is about infective endocarditis. Outlines definition of infective endocarditis, epidemiology, pathogenesis, microbiology, clinical features, and diagnosis. Infective endocarditis, defined as community-acquired or healthcare-associated infection with the microorganism colonizes a focus in the heart, producing fever, heart murmur, splenomegaly, embolic manifestations, and bacteremia or fungemia. Epidemiology, the annual incidence of infective endocarditis is estimated to range from 1.7 to 7% episode per 100,000 persons in North America. Incidence of prosthetic valve, aortic valve endocarditis is estimated from 0.2 to 1.4 episode per 100 patients. Approximately 1.4% of patients undergoing aortic valve replacement will develop prosthetic valve endocarditis during the first postoperative year. Infective endocarditis usually affects the left-sided valve, mitral more than aortic. 5% of cases involving the tricuspid valve and pulmonary valve rarely being affected. Among patients with aortic valve endocarditis, congenital, yes.
Can you make the slide a little bit bigger because we can? The slide is not in the view mode, I think. Or the presentation mode. Because we can see two slides.
Which slide now appear? Epidemiology?
I think this is the design of the slide itself, you know? That's why.
Okay.
Zoom it from your device. Yeah.
I think this is the speaker's view.
Yeah, exactly.
Speaker view.
Okay.
I didn't get it. It's not clear or what?
It's okay. It's okay. Zoom it from your devices, guys.
Okay. Among patients with aortic valve endocarditis, congenitally bicuspid aortic valve is the most common predisposing lesion. Other lesions like degenerative calcific aortic stenosis, aortic insufficiency secondary to connective tissue disorder, and rheumatic aortic valve disease also predisposing lesion for this infection. Dental extraction and endoscopic procedure demonstrated to produce bacteremia. Intravenous drug users are particularly susceptible to infective endocarditis, which often occur in structurally normal heart valves. Pathogenesis. Normal cardiac endothelium is resistant to infection. Even with transient bacteremia, normal immune mechanism inducing thrombocytin, which is protein released by platelet, will prevent this endocarditis. Risk factors for native valve endocarditis include endothelial disruption, valvular lesion such as aortic stenosis or mitral regurgitation resulting in non-laminar flow. This risk factor induced platelet fibrin thrombus formation with subsequent bacterial colonization resulting in vegetation formation and spread into the surrounding tissues or embolization. Infective endocarditis of aortic valve not only causes disruption of the cusp, paravalvular abscess, or cardiac fistula, also can cause coronary and systemic embolization of vegetation, like cerebral infarction, either ischemic because of arterial occlusion or hemorrhagic because of rupture of mycotic aneurysm. Aortic valve endocarditis with large vegetation that prolapse in the left ventricles comes in contact with the anterior leaflet of the mitral valve, can cause secondary involvement to the mitral valve. Infection of the mechanical heart valve is usually located in its swing ring. Infection of porcine or pericardial valve involve the cusp and swing ring or both. Infection of aortic valve homograft and pulmonary autografts resemble that of the native aortic valve. It begins in the aortic cusp and destroys them, causing aortic insufficiency, and extend to the surrounding structures. Commonest organisms in patients with native valve infective endocarditis: Streptococcus viridis in 45% and Streptococcus bovis, Streptococcus aureus or epidermidis in 35%, Enterococcus facialis, diphtheroid bacilli, and microaerophilic Streptococcus, HACEK organism, anaerobic gram-negative bacilli, Fusobacterium, Bacteroid, Streptobacillus, Propionibacterium, Listeria, monocytogenes, Procella, and Legionella, Coxella burnetii, Chlamydia psittaci or Trichomatis, fungal like Candida, Aspergillus, and Histoplasma. HACEK organism, it's a group of gram-negative fastidious bacilli that required prolonged culture in 10% CO2, like Haemophilus species, Acintobacillus, Cardiobacterium hominis, Econella corrodens, Kingula kingi. Commonest organism in patients with early, less than 2 months prosthetic valve endocarditis by Streptococcus aureus and epidermidis, gram-negative bacilli, fungi, Streptococcus and Enterococcus in less than 10% of cases. Commonest organism in patients with late more than 2 months prosthetic valve endocarditis caused by Streptococcus viridis, Staphylococcus aureus and epidermidis, Enterococcus facialis. Causes of culture-negative infective endocarditis: prior antibiotic therapy, slow-growing or fastidious organisms, fungal endocarditis, obligate intracellular parasite like Coxella burnetii or Chlamydia, non-infective endocarditis, marantic endocarditis. Causes of non-infective endocarditis: marantic, first, mucinous adenocarcinoma in pancreas, lung, or upper GIT, other malignant disease like a lymphoma, bladder carcinoma, antiphospholipid syndrome, Haas syndrome, acute rheumatic fever caused by group A beta hemolytic streptococcus, Liebman-Sachs endocarditis in SLE and scleroderma. Causes of persistent or recurrent fever in patients with suspected infective endocarditis on antibiotic treatment, wrong antibiotic or wrong diagnosis, spread of infection like in cases of paravalvular or intracardiac abscess, metastatic infection or mycotic aneurysm, secondary infection like in case of hospital-acquired chest infection, venous line infection, antibiotic hypersensitivity usually caused by penicillin. Classification of infective endocarditis classified into subacute, caused by less virulent microorganisms such as Staph viridis, Streptococcal viridis, antibiotic for weeks to 10 days alone cure most cases. Acute, caused by virulent microorganisms such as Staph aureus and maybe affect normal valve. Antibiotic alone fail to cure this infection. Clinical feature of infection like a fever, night sweat, rigor, weight loss, malagia, anemia, and clubbing, splenomegaly in chronic cases. Clinical feature of immune complex like a rota spot, which is retinal pot-shaped hemorrhage with pale center, splinter hemorrhage, which is a thin reddish brown line in nail bed, osseous nodule, painful bulb infarction in the finger, or genuine lesion, which is painless erythema in the palm. Clinical feature of cardiac lesion: new or changing murmur, heart block, heart failure, and biopericardium. Clinical feature emboli occur in any part of the body, cause infarction or abscess, especially with fungal endocarditis due to febrile emboli. Investigations, laboratory CBC will show anemia without reticulocytosis, especially if the patient untreated for more than a few weeks. Leukocyte count is moderately elevated, blood culture showing the microorganisms. Imaging, Doppler echo, transesophageal echo is usually better than transthoracic echo. It can detect vegetation as small as 1 to 2 millimeter in the size, more reliable in the native than prosthetic valve, and more useful in tissue than mechanical valve. Heart catheterization and coronary angiography increase the risk of embolization, especially in aortic valve vegetation, so should be avoided. CT images useful in these cases. Modified Ducks criteria for diagnosis of infective endocarditis. Major criteria. First one, blood culture positive for infective endocarditis. Typically microorganism consistent with infective endocarditis from 2 separated blood culture, Streptococcus viridans, Streptococcus bovis, HACEK group, or community-acquired enterococci in absence of primary focus or microorganism consistent with infective endocarditis from persistent positive blood culture, defined as following: at least 2 positive cultures of blood drawn for more than 12 hours apart, or all of 3 or majority of more than 4 separate culture of the blood, while the first and last sample drawn at least 1 hour apart. Single positive blood culture for Coxella bonity or phase 1 immunoglobulin G antibody titer for Coxella bonity more than 1 to 800. Second, evidence of the endocardial involvement. Echo positive for infective endocarditis. Transesophageal echo recommended in patients with prosthetic valve, at least as possible endocarditis by clinical criteria, or complicated endocarditis, such as paravalvular abscess. Transthoracic echo as the first test in other patients as follows: oscillating intracardiac mass or valve or supporting structure in the path of regurgitation jet or implant material in the absence of the alternative anatomical explanation. Abscesses, new partial dehiscence of prosthetic valve. Last one, a new valvular regurgitation showed by worsening or changing of pre-existing murmur not sufficient. Ducks minor criteria, predisposing factor like cardiac lesion or intravenous drug abuser, fever more than 38, embolic or vascular phenomena such as splinter hemorrhage vasculitis, immunological phenomena like osseous nodule rust spot rheumatoid fever, microbiological evidence of positive blood culture but doesn't meet a major criteria as noted before, or serological evidence of active infection with an organism consistent with infective endocarditis. Significance of Ducks criteria: defined endocarditis with 2 major criteria or 1 major plus 3 minor criteria or 5 minor criteria. Possible endocarditis if 1 major plus 1 minor or 3 minor criteria. This is a picture of the tricuspid valve vegetation affected septal and anterior leaflet. Rejected diagnosis of endocarditis. In case of firm alternative diagnosis, resolution of the manifestation within 4 days of antibiotic treatment, no evidence of infective endocarditis at surgery or postmortem after therapy of more than 4 days. Any questions?
Okay, thank you, Dr. Ghada. Any question for Ghada or comment? Okay, since there are no more questions, we'll have a quick break for 5 minutes and then we'll start with the second lecture. Thank you. Shada?
Yes, hello.
Yes, you can start.
Okay. الشاشة واضحة والصوت واضح؟
Yes.
Okay. بسم الله. Today my lecture about ASC guideline for management of infective endocarditis. So a quick definition: infective endocarditis is infection of the endocardial surface of the heart, which may include one or more heart valves, the mural endocardium, or septal defect. Variation of infective endocarditis were uncommon in the early antibiotic era, have become prominent. Causes of native infective endocarditis, IV drug abuse, infective endocarditis, and prosthetic valve infective endocarditis have markedly increased. So antibiotic prophylaxis, it's used to prevent the attachment of bacteria onto the endocardium after transient bacteremia following invasive procedure. This concept lead to recommendation for antibiotic prophylaxis in large number of the patient with predisposing cardiac condition undergoing a wide range procedure. So who is the population at risk? First, patient who with the prosthetic valve or with the prosthetic material used to cardiac valve repair. These patients have highest risk of infective endocarditis. Patients with previous infective endocarditis, they also have a greater risk of a new infective endocarditis. And also patients with untreated cyanotic congenital heart disease, and those with congenital heart disease who have post-operative palliative shunt, conduit, or other prosthesis after surgical repair with no residual defect. The task force recommend prophylaxis for first 6 months after procedure until industrialization of the prosthesis material have occurred. Non-specific prevention measure to be followed in high-risk and intermediate-risk patient. 1. Strict dental and continuous hygiene. Dental follow-up should be performed twice a year in high-risk patient and yearly in others. Disinfection of the wound and eradication or decrease chronic bacterial carriage in the skin or urine. A curative antibiotic for any focus of bacterial infection, no self-medication with antibiotic, strict infection control measure for any at-risk procedure, discourage bracing or tattooing, limit the use of infusion catheter and invasive procedure when possible, favor peripheral over the central catheter, and systemic replacement of the peripheral catheter every 3 to 4 days. What procedure requiring antibiotic prophylaxis? A dental procedure, antibiotic prophylaxis should only be considered for dental procedure requiring manipulation of the gingival or periapical region of the teeth or perforation of the oral mucosa. It's class 2C. Antibiotic prophylaxis is not recommended for local anesthesia injection in non-infection tissue, treatment of superficial caries, or removal of suture and dental X-ray, placement or adjustment of the removable prosthodontic or orthodontic applicants, or brace or following the shedding of decondus teeth or trauma to the lip and oral mucosa. It's class 3C. In respiratory tract procedure, antibiotic prophylaxis is not recommended for respiratory tract procedure, including bronchoscopy, or laryngoscopy, or transnasal or endotracheal intubation. And gastrointestinal or urological or TEE, antibiotic prophylaxis is not recommended for gastroscopy, colonoscopy, cystoscopy, vaginal or cesarean delivery or TEE. Skin soft tissue procedure, antibiotic also not, prophylaxis is not recommended for any procedure. Recommended prophylaxis for high-risk procedure and high-risk patient. What antibiotic usually used in situation no allergy to penicillin or ampicillin. You have to use ampicillin or amoxicillin 2 gram orally or IV, and for children 50 milligram per kg orally or IV. If the patient have allergy to penicillin or ampicillin, use clindamycin 600 milligram orally or IV for children, 20 milligram per kg orally or IV. There is alternatively cephaloxine 2 gram IV for adult or 50 milligram per kg IV for children, and cefazoline or ceftriaxone 1 gram IV for adult or 50 milligram per kg IV for children. Cephalosporin should not be used in patients with anaphylaxis or angioedema or urticaria after intake of penicillin or ampicillin due to cross-sensitivity. A recommendation for antibiotic prophylaxis for prevention of local antisystemic infection before cardiac or vascular intervention. The recommendation is perioperative screening of nasal carriage of Staphylococcus aureus is recommended before elective cardiac surgery in order to treat the caries. It's class 1A. And perioperative prophylaxis is recommended before a placement of a pacemaker or implantable cardioverter defibrillator, it's class 1B. And potential source of sepsis should be eliminated more than 2 weeks before implantation of prosthetic valve or other intracardiac or intravascular foreign material except in urgent procedure. Perioperative antibiotic prophylaxis should be considered in patients with undergoing surgical or transcatheter implantation of prosthetic valve, intravascular prosthesis or other foreign material, it's class 2C. Systemic local treatment without screening of Staph aureus is not recommended, it's class 3C. So the role of echocardiography in infective endocarditis for diagnosis, use the transthoracic echocardiography is recommended as a first-line imaging modality to suspected infective endocarditis. TEE is recommended in all patients with clinical suspicion of infective endocarditis and negative or non-diagnostic TTE. TEE also recommended in patients with a clinical suspicion of infective endocarditis when prosthetic heart or valve or intracardiac device is present. Repeat transthoracic echocardiography or transesophageal echocardiography within 5 to 7 days is recommended in case of initially negative examination when a clinical suspicion of infective endocarditis remain high. Echocardiography should be considered in Staphylococcus aureus bacteremia. Transesophageal echocardiography should be considered in patients with the suspicion of infective endocarditis, even in case with positive transthoracic echocardiography, except in isolated right-sided native valve, infective endocarditis with good quality transthoracic echocardiography. Examination and unequivocal echocardiography finding. Use echocardiography for follow-up under medical therapy. Repeat transthoracic or transesophageal are recommended as soon as a new complication of infective endocarditis suspected, like a new murmur or embolism or persistent fever, heart failure, abscess, and atrioventricular block. Repeat transthoracic or transesophageal echocardiography should be considered also during follow-up of uncomplicated infective endocarditis in order to detect a new silence complication and to monitor the vegetation size, the timing of mode of repeat examination, depend of initial finding, type of microorganism, and initial response to therapy. Using echo intraoperative is recommended in all cases of infective endocarditis requiring surgery, and following completion of therapy, TTE is recommended as at completion of the antibiotic therapy for evaluation of cardiac and valve morphology and function. So, what indication for infective endocarditis and use of echo? First, start with transthoracic. If it's positive or not diagnostic or prosthetic valve is intracardiac device, go for TEE directly. If it's negative, see the patient clinically. If the patient you have high suspicion of infective endocarditis, go for transthoracic, or you have to stop. So what's the causative organism? Streptococci, it's from 60% to 80%, and streptococci variant from 30 to 40%, other streptococci 15 to 25%, enterococci from 5 to 18%, coagulase positive organism 10 to 27%, coagulase negative organism from 1 to 3%, gram-negative aerobic bacilli from 1 to 13%, fungus infection from 2 to 4%, and staphylococci from 20 to 35%. An IV drug user, the most common etiology agent of the infective endocarditis is Staphylococcus aureus, also more commonly seen in Pseudomonas aeruginosa, especially if the drug abuser is using pentazocine. If the drug abuse with heroin, you have too high suspicion of candida infection. In prosthetic valve, in patients with prosthetic valve, the microbiology and somewhat depend on the early, which is more than less than 12 months of implantation, and late, more than 12 months of implantation. If it's early, the most common organism is coagulase negative Staphylococcus from 30 to 35%. Staphylococcus aureus from 20 to 25%, and gram-negative bacteremia 20%. If it's late, it's the same organism like a native valve disease. We have also HACEK organism. HACEK organism is acronym for a group of fastidious, slow-growing gram-negative bacteria, account for approximately 5 to 10% of the cases of community-acquired endocarditis. H for Haemophilus parainfluenza, Haemophilus afrophilus, and Haemophilus paraafrophilus, and Haemophilus influenza. A. Acetobacillus. C. Cardiobacterium. E. Echinella, and K. Echingella bacteria. So how to do investigation for rare causes of infective endocarditis if the blood culture came negative? If the pathogen is Brucella, use blood culture specific for Brucella to grow with, and serology and immune histology and PCR. Coxella, also use serology, IgG, and tissue culture, immunohistology, and PCR. Proteinella is use blood culture and serology culture, immunohistology, and PCR. Trophrema is histology and PCR of the surgical material. Mycoplasma, serology culture, and histology and PCR. Legionella, blood culture, serology culture, immunohistology, and PCR. And fungus infection, blood culture, serology, PCR, and surgical material. So this is modified criteria for the diagnosis of infective endocarditis. Dr. Awad just mentioned about the major and minor criteria, so do not repeat it again. And she mentioned also about modified Duke criteria. So prognosis factor, predictor of poor outcome in patients with infective endocarditis and patient characteristic like old age and prosthetic valve, infective endocarditis, diabetic mellitus, and comorbidity like frailty, immunosuppression, renal or pulmonary disease. Clinical complication, if the patient have clinical complication of infective endocarditis, which is go with more worse prognosis like heart failure, renal failure, more than moderate area of ischemic stroke, brain hemorrhage, septic shock. If the patient have a microorganism like Staphylococcus aureus, fungus infection, and non-HACEK gram-negative bacilli, also worse prognosis. In echo finding, like periannular complication, severe left-sided valve regurgitation, low left ventricular ejection fraction, pulmonary hypertension, large vegetation, and severe prosthetic valve dysfunction, and premature mitral valve closure, and other sign of elevated diastolic pressure. All of these give us worse prognosis of infective endocarditis. So antibiotic therapy, antibiotic treatment for infective endocarditis due to streptococci and Streptococcus bovis if the patient has penicillin susceptible. Standard to start with penicillin and ampicillin or ceftriaxone for 4 weeks, or to start with 2 weeks of penicillin or ampicillin or ceftriaxone, but combined with gentamicin or nitroamycin. If the patient have beta-lactam allergy, give the patient vancomycin. If the patient have strain related to resistance to penicillin, so start with standard treatment, penicillin or ampicillin or ceftriaxone combined with gentamicin. And in beta-lactam allergy, vancomycin with gentamicin. Antibiotic for Staphylococcus aureus. For native valve, methicillin susceptible staphylococci, start with cloxacillin or oxacillin, or alternative therapy like cotrixazole with clindamycin. If the patient have penicillin allergy or patient with penicillin resistant staphylococci, vancomycin and or daptomycin and or cotrazazole with clindamycin. If the patient have prosthetic valve, methicillin susceptible staphylococci, cloxacillin or oxacillin with rifampin and gentamicin. And if the patient have penicillin allergy, start with vancomycin with rifampin and gentamicin. Antibiotic for the enterococcus, beta-lactam and gentamicin susceptible strain, start with amoxicillin with gentamicin, or amoxicillin with ceftriaxone, or vancomycin with gentamicin. If the patient have culture negative infection endocarditis, brucella, most common antibiotic used with the brucella is doxycycline. If the patient have cipronate, doxycycline, Rotronella, also doxycycline, Legionella, levofloxacin, Mycoplasma, levofloxacin, and Tryptophan wabili, it's doxycycline. If the patient have HACEK-related species, standard treatment with ceftriaxone 2 gram per day for 4 weeks in native valve and for 6 weeks for prosthetic valve. If the patient infected with fungus infection, its mortality rate is very high, like 50%, and treatment state combined antifungal and surgical valve replacement. If the patient have candida infective endocarditis, amphotericin B or ecocandine at high dose, or if the patient have aspergillosis, infective endocarditis, voriconazole is the drug of choice. And some experience recommend to adding an ecocandine or amphotericin B. Proposed antibiotic regimen for initial empiric therapy for infective endocarditis in acute severely ill patient before pathogen is identified. Start empirically with ampicillin with cloxacillin or oxacillin with gentamicin, vancomycin with gentamicin, or vancomycin with gentamicin with rifampin. Then if the culture is positive, then specific the antibiotic for that group of the bacteria. Indication for surgery, like if the patient have heart failure, aortic or mitral native or prosthetic valve with severe regurgitation, obstruction or fistula causing refractory pulmonary edema or cardiogenic shock, aortic or mitral native or prosthetic valve with severe regurgitation or obstruction causing symptom of heart failure or echocardiographic sign of poor hemodynamic tolerance. An uncontrolled infection like locally uncontrolled infection, abscess, false aneurysm, fistula, and enlarged vegetation, or infection caused by fungus or multi-resistant organism, or if the patient have persistent positive blood culture despite appropriate antibiotic therapy and adequate control of the septic metastasis foci, or if the patient have prosthetic valve caused by staphylococcus or non-HACEK gram-negative bacteremia. You can go for surgical management to prevent emboli like aortic or mitral native or prosthetic valve with persistent vegetation more than 10 millimeter after one or more embolic episode, despite appropriate antibiotic therapy. Aortic or mitral native valve with vegetation more than 10 millimeter associated with severe valve stenosis or regurgitation and low operative risk. Aortic or mitral native or prosthetic valve with isolated very large vegetation more than 30 millimeter. Aortic or mitral native or prosthetic with isolated large vegetation more than 15 mm and no other indication for surgery. Indication for surgery, surgical treatment of the right-sided infective endocarditis. Surgical treatment should be considered in the following scenario, like microorganism difficult to eradicate, persistent fungus or bacteremia for 7 days, Staphylococcus aureus or Pseudomonas aeruginosa despite adequate antimicrobial therapy, or persistent tricuspid valve vegetation 20 millimeter after recurrent pulmonary emboli with or without concomitant right heart failure, or right heart failure secondary to severe tricuspid regurgitation with poor response to diuretic therapy. What are the factors associated with increased rate of relapse? Inadequate antibiotic treatment, like false agent, dose not adequate or the duration is not adequate for treatment. Resistant microorganism, most common Brucella, Legionella, Chlamydia, Mycoplasma, and Mycobacterium, Proteinella, and Coxella, and fungus infection. Or the patient have polymicrobial infection, an IV drug abuser, empirical antimicrobial therapy for drug abuser, or periannular excision, prosthetic valve endocarditis, persistent metastasis foci of infection, abscess, resistant to conventional antibiotic regimen, and positive valve culture, persistence of fever at 7th post-operative day, and chronic dialysis. Cardiac device related to infective endocarditis. Diagnosis, 3 or more set of blood culture are recommended before prompt initiation of antimicrobial therapy for cardiac device associated infection. Lead tip culture is indicated when the cardiac device is explantable. And TEE is recommended in patients with suspected cardiac device-related infective endocarditis with positive or negative blood culture, independent of the result of the transthoracic echocardiography to evaluate lead-related endocarditis and heart valve infection. Intracardiac echocardiography may be considered in patients with suspected cardiac device-related infective endocarditis, positive blood culture, and negative TTE and TEE result. Radiolabel leukocyte sensogram and FDG and PET-CT scanning may be considered as additive tool in patients with suspected cardiovascular-related infective endocarditis, positive blood culture, and negative echocardiography. So principle of treatment, prolong before-after extraction of antibiotic therapy, and complete hardware, device, and lead removal are recommended in definitive cardiac device-related infective endocarditis, as well as presumably as isolated pocket infection. Complete hardware removal should be considered on the basis of occult infection without another appearance of source of infection, and in patients with native valve or prosthetic valve and in intracardiac device with no evidence of associated device infection, complete hardware extraction and may be considered. Mode of device removal, either percutaneous extraction is recommended in most patients with cardiac device-related infective endocarditis, even those with vegetation more than 10 millimeter. Surgical excision should be considered if the percutaneous extraction is incomplete or impossible, or when there is association severe destructive tricuspid infective endocarditis. Surgical extraction may be considered in patients with large vegetation more than 20 ml. Reimplantation and prophylaxis. After device extraction, reassessment of the need of the reimplantation is recommended. One indication defined, reimplantation should be postponed if possible to allow a few days for weeks of antibiotic therapy. A temporary isolated active fixation strategy may be considered in pacemaker-dependent patients requiring appropriate antibiotic treatment before reimplantation, and temporary pacing is not routinely recommended. For prophylaxis, routine antibiotic prophylaxis is recommended before device implantation, and potential source of sepsis should be eliminated for more than 2 weeks before implantation of intravascular cardiac foreign material, and except an urgent procedure. So infective endocarditis and congenital heart disease. There is a few systemic studies about this topic, but the incidence is lower in children at 0.04% per year than in adult 0.1%. Congenital heart disease with multiple lesion is at high risk than simple lesion. Mortality of 4 to 10%. Prognosis is better than other forms, and surgical repair of congenital heart disease reduce the risk and provide there is no residual shunt, and artificial valve substrate may increase the risk of the infective endocarditis. Infective endocarditis during pregnancy, incidence is 0.006% and higher in patients with cardiac disease, and furthermore in patients with prosthetic valve. Maternal mortality is approximately 33%, with most deaths related to heart failure or embolic event. Fetal mortality is about 29%, and rapid detection and appropriate treatment is important. Despite the higher fetal mortality, urgent surgery should be performed in the patient who present with heart failure due to acute regurgitation. So this is the end of my presentation. Any question? Any question or comment?
Thank you, Shada. I can see Dr. Shabir and Dr. Atizaz. I would like to welcome them to our activity. Not sure if they have any comment from their side. Dr. Atizaz or Dr. Shabir.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
A nice presentation. I joined in the middle. So, but I think she presented a very focused, nice presentation, guideline directed presentation. Yes, I think is there any second presentation after this, or this is the guideline?
Yeah, this is the last one.
Okay. So, from practical, clinical point of view, we have to be aggressive in this. So now it is better to operate them early. So whenever I see an infective endocarditis, I just go and see he needs surgery. He is not febrile, few days antibiotics, I take them. So it is better to operate them early rather than waiting for a long. There are lots of studies which which show that early surgical intervention has a better long-term prognosis, and they do well. Rather than waiting for long and heart failure, patient is doing okay, let us continue antibiotics for 6 weeks and then call him. Then we'll see whether he has any regurg or damage in the valve. So the practical point is, even in the patient is CCU, these patients are best, even the patient is sick, if you leave like he's very sick, and medical management is not good as a surgery. Surgery has a better outcome, whether patient is stable or unstable. So clinical point of view, real world practice for me, be aggressive with them and just fix them as early as possible. So type of valve taking, like whether you do the mechanical or the tissue, I don't think there is a big difference between the two. So it depends on the patient is young, whether if there's an indication of mechanical, I go with mechanical. If the patient needs tissue, is elderly or other indication of tissue, I go with the tissue. So this is how I do my practice. If you guys have any questions, and I will try to answer.
So Dr. Atizaz means that my question is, what are the patients that I will delay the surgery or wait? Are there any? Because I saw some patients during my R1, R2 that they are really delaying the patient till because she or he in a failure or something. So what things that make me waiting?
See, if you have a patient who's let us make a case scenario. I got a patient has a vegetation, has a lot of vegetation, and he had now one embolic syndrome. Okay, let us guess it. And she had a mild TIA, some she recovered. Now there is a vegetation. What should we do? And there is an MR, moderate MR. I will go and fix it. I will not wait for the, now they will say the patient is doing fine, let us complete the antibiotic. No need of completing that. Patient already antibiotics on board. You have already cultures, I don't know, positive or negative. So the patient is stable, doing well, you just go ahead and fix him. Now I have another patient, like you have suppose endocarditis, and patient has a moderate to severe MR. So, but the LV is not dilated, patient not in heart failure, right? So, here you have an option, right? No, patient has a severe MR, but he is not LV, let us wait for the antibiotic. I just go and treat him and operate him. So, yes. So even I did like, double ball or triple ball, or like sometimes, yeah. So we go and operate them, particularly when patient becomes sick, cardiologist will be after you. You have to fix it. Yeah, that time the risk is high, mortality is high. Even though you have to take it, you cannot refuse, to be honest. I don't, infective endocarditis, the only hope is to remove this source of infection. Because sometimes if you have an infective aortic valve infection, you wait and then it becomes abscess, root abscess, we have seen, and then it becomes terrible for a surgeon. It really, it creeps inside and goes into the root, and then you have abscesses, you have root abscesses, you have some, then it becomes really difficult. So the
Yeah.
bottom line in infective endocarditis is be aggressive and treat surgically.
Yes. What about if is there any patient that cannot or will not benefit from surgery, for example? Like they will keep them on antibiotics and will not go for surgery, for example, the
Yes.
high risk one.
Yes, yes. No, like if you have there is a small vegetation, few millimeter, patient does not have heart failure, and there is no MR, there is no other valvular issue. Yeah, antibiotics can heal, and there do a follow-up echo, no need of operation. Absolutely. I mean, whenever there is an indication of surgery, don't wait for long. That is all.
Okay, thank you.
Yeah, just don't delay and keep and let us see. Just aggressive. Whenever there is indication, just be aggressive. Rather than delaying, let us do a next week and see. Let antibiotics work. What I have seen, let antibiotics continue another few days or few weeks. Patient is relatively stable, and let us see next week. I don't do that. This is my practice. Whenever their patient becomes surgical indication, whatever, I just try to operate as early as possible.
Shabir?
Yes.
Yeah, thank you for those comments. I just have a question. Patients with embolic strokes, not hemorrhagic or any, those patients with infective endocarditis, of course, how long we should wait for them? We have documented stroke, and is it like, I read somewhere like, is it 4 days, or is it we treat them as a major stroke and the risk of hemorrhagic transformation? Is it after 4 or 5 days it's enough, or shall we wait more? What is your practice?
See, if you have an infective endocarditis showering, it depends on. Let's say patient he has a minor, as I said, minor DI. You do a CT scan, there is hardly any visible. Just maybe I'll be hesitant to do him same day, but maybe after a few days I will take him. This is number one. If the patient has a major stroke and is a deficit, now here becomes, suppose it is an ischemic stroke. I usually take a neurology on board. They do not contraindicate. They just say, it is as a medical legal, it's a moderate high risk for the complication post-operative stroke. Usually 2 weeks is better to wait for 2 weeks. Okay. If it's a major big stroke, ischemic, not an hemorrhagic. Of course, hemorrhagic stroke, it is better to wait at least, if it's a big hemorrhagic stroke, it is better to wait more than 2 weeks, around 4 weeks. So if you have a small strokes and, emboli and patient, you will go to CCU, cardiology will say, yeah, he had some deviation, maybe he's showering. If you do an MRI for them, you will see lots of small hemorrhagic brain hemorrhages, very tiny, which you cannot see on a routine CT. So yes, so those my tiny hemorrhages are really, I'm not too many cases done, but I had a couple of patients who had some minor stroke, then recovered. Then we did an MRI, and we showed there was a multiple hemorrhagic spots all over the brain. We call a cardiac, of course, neurology take their opinion and kind of high risk. But I remember 2 patients, alhamdulillah, they made a very uneventful recovery. They were sick, they were intubated, and then eventually, alhamdulillah, they did a good recovery. So bottom line is, wait, as you said, few days. If there is a small stroke, if there is a big ischemic stroke, if patient condition allows, it is better to wait for 2 weeks. If the patient has a hemorrhagic stroke, better wait 4 weeks. This is a rough, like you are. Then you can change your practice, depends on the condition and the other factors involved.
I see.
Okay. Yeah. So each patient has to be individualized. This guideline is, they just help you what should we do, but at the end, each patient has to be individualized. So usually, if after 2 weeks, ischemic stroke, there is usually it doesn't transform into the hemorrhagic stroke. What is a fear? There is always chance, but the risk comes down really, really very low.
Mhm. Okay, Victor, thank you. And just another question. Patients with tricuspid valve endocarditis and with severe regurg, those patients, since they don't have like some kind of right-sided increased pressure, or they is it true that they tend to tolerate this tricuspid regurg more, and such patients we can, if even with tricuspid severe TR, we can tolerate it for some time, because those patients with IV drug abuse tend to come back. What is, or is it we treat it as indication for surgery and should be taken to repair?
See, if you have a tricuspid valve and it has a vegetation, then because the valve is destroyed, it has a TR. So how it will improve? It will not improve. So you have to fix it. And the severe TR, they don't have a long good-term prognosis. Do they tolerate? Yes. If they are not septic, right side is different. See, if you have a right-sided endocarditis and you have a TR, which is like moderate or severe, and patient is not helping, they tolerate. Yeah, no need of urgency in these cases. But if you have a severe TR now and patient is like, he's not septic, this patient still needs indication of surgery, because now the valve is destroyed. It is not going to go better anyways, because the healing is contraction or fibrosis. So these patients will need eventually surgery. Now he has a primary, let us, infection is controlled. Now you have what? You have a primary tricuspid valve pathology, say big secondary to it. It is not because of the secondary, because of the RV dilatation or pulmonary hypertension. So indication will here, you are done with the infection, it is healed. Now the indication will lead to the severe TR, primary valve pathology with severe TR. So he will fall in that category now. Should we rush him? No need of rushing him. But eventually he will need, because the problem is that the severe TR, the long-term prognosis is not good. So if the patient is tolerating diuresis, you can wait for this patient, but not rushing. But eventually he is a surgical patient, but not as an emergency. And if your cardiologist look, the valve is looking like very bad, and this TR is going to worse, so I think there is reasonable surgery, and go and fix it. But if the patient wants to delay and RVS doesn't have the volume load and kind of right heart, you can wait. But to me, this patient is a surgical. Any patient who has destroyed valve because of the infective endocarditis, even though he is not septic no more, we have to fix this tricuspid, and he's a surgical. It is only a matter of time. Rest, it is a surgical.
Okay, thank you. So, just the last question. What is your practice regarding dental checkup prior to valve surgeries? Is it for you a mandate or a must for every single patient to go through a dentist checkup, or is it just in the clinic, pre-surgery clinic, our surgeons just general checkup of the dentist, of the teeth, if it's fine or not? What is your thought on that?
Different. Everybody has a different practice in this. When I was in Canada, there it is easy to, the patient goes to his primary family dentist or something. He gets a letter, and it is done. And there is a very good protocol for that. So we are doing like this. When we come here, the problem here is, you send a dentist, the private dentist, he is scared, he doesn't see them, and they don't have their own dentist. Everybody cannot go to private. Then you send up to, like in our hospital, if you send to the dental department, it takes sometimes a very long time, even the admitted patient. Correct. So my practice varies with patient to patient again. If I check my the teeth myself. If I feel like he doesn't have a gross infection and patient is comfortable, I explain what is a dental this relation with the valve. I sometimes operate without any dental care. If I feel that these teeth are very bad, he has many things, and then and patient is not an urgent, so I refer him to the dentist. So sometimes I do, sometimes I don't do. Suppose I have a severe aortic stenosis, I don't usually refer to the dentist. Suppose the aortic valve stenosis is very severe, patient has some symptoms, he has now, and LV has gone down, and the valve area is very severe, say 0.4, 0.6. I don't send them to the dentist. They are very at risk. I have seen one patient having arrhythmias during the, I think, V fever, V attack, long back. So this is so like that. So I will not do. If the patient has a simple, say, mitral regurg, has a severe, but he is not in heart failure, just an indication, very low risk, and his teeth are pretty bad. So I will, okay. Anyway, he's not going far soon for surgery. I will refer him to the dentist. So so for dental consultation, I individualize the patient. Sometimes I do, depends on the dental hygiene. I check myself teeth, and I do not refer the severe aortic stenosis to the dentist. Usually, unless there is a really pain or that his examination shows a gross infection. Usually not.
I see. I see. Very clear. Thank you, Dr. Shabir.
Okay.
Dr. Shabir,
Yes.
do you have any experience with the aortic homografts? So some papers showing that it is more resistant to infection. So
yeah. Textbooks regarding, but no personal. It is in the textbooks, and there has been good results, but no personal experience.
So you don't go for a homograph, you just either.
I don't have, so I have no
physical.
option. So I have no personal experience. So maybe, those who have those banks and valve banks or something, some hospitals, yes, I have seen some surgeons. But personally, since my practice, I either do a tissue, or do a mechanical. So I really difficult. But yes, there are, they say homography more resistant to infection. Yes, I agree with this statement. Okay.
Thank you.
Yeah.
Thank you. Any other questions for Shada or Dr. Shabir?
Just this one last. Sorry, just one last question. Dr. Shabir, when the infective endocarditis involving very, I don't know if it's maybe it's at the time of aortic surgery, better to discuss it. But since we are on the topic of infective endocarditis, such cases, as you said, you leave them for some time, the abscess will enlarge and like it will involve the root and maybe to the mitral. Such cases, so what's the strategy? Is it like to do, if it's very severe infection involving the root, and is it like to treat medically and then wait for the infection to settle, and then, or just or surgical to debride all this area and then try to reconstruct?
In aortic position, you mean? When there's an aortic position,
involving the root and then maybe
so it is a difficult situation. If there is an infective endocarditis aortic valve, now if the patient has an indication of surgery, like patient is the valve, there is a severe AI, there is some vegetation, or he had some embolic phenomena, or whatever the reason is. So go and fix it. Don't wait. Don't wait the abscess. Now you said there is query abscess, there is yes abscess, no abscess. You put a patient on CT scan, and they are not sure. You go and operate this patient. They are not going to treat the CT scan people or a TE. They are not going to solve your problem. So yes, you go with a plan. When you do a CT scan, you do TE. You have in your mind what you are going to face. How suppose there is an aortic valve and you are treating. So I will do a caval cannulation. So I don't know. I might have to open the mitral. I may have to reconstruct, do commando kind of thing. So you have to be ready with the plan. So when you have done a very good thorough examination, thorough assessment of the patient, CT scan, So your planning is better. So you have in your mind, I may land in one valve, I may land in root valve replacement, I may land in mitral valve, and may need very rarely, you know, those, as you maybe you may need even in commando. So it depends on the situation. I will give an example. I did a 2018. I did a valve patient one. He was infective endocarditis. So I operated his vegetation, some embolic phenomena. Anyways, it was valve was destroyed, so I replaced the aortic valve. The mitral was reported. You know, usually there nothing was mentioned in the echo or something. When I opened the aortic valve, I saw small vegetation. You know, those seedlings, small on the mitral valve. So I shaved it. I threw the aortic valve. So I slightly peeled and examined. Everything looked not reddish, but it was, you know, the angry looking, but it was not a grass thing. So I fixed the aortic valve and closed it and cleaned the mitral only. Then when I did a post-op echo in the OR, there was nothing major issue. They were there. They said, you know, there is a very tiny leak we can see below, but they were not close to the aortic valve. I said, no, I'm not going to back. He's a sick patient. Let us transfer him. When we were going to post-op, no, they say there is something leaking in the base of the mitral, but it is not that big. But there is something, my moderate kind of thing. I said, no, look, let us continue his antibiotic therapy and discharge. After about 2 weeks back, you know, he was following our clinic. So he came with a big perforation of the anterior mitral leaflet. And he was having severe MR. I'm 6 months back. Then I have to go and fix his mitral recently, you know, so do a redo. Alhamdulillah, he did a good. So depends on. Sometimes, you know, you have to be careful about those if you have to do shaving or something in the mitral. So, you know, you may perforate or this because this is an infection. If there is, even though you don't appreciate perforation that time, if there is a thin, it may heal with some destruction. So when you are doing shaving, this is what I learned. So, you know, shaving and cleaning, apparently it got nothing to be done. It may heal with fibrosis, and later on, it may lead to some valve regurg or whatever, or stenosis. So that is why, you know, I should have done before, should have replaced the valve. I don't know. But, you know, sometimes it is a learning that, you know, sometimes they heal with perforation. So if you see a gross valve abnormality, you may have to replace.
Okay, thank you, Dr. Javed.
Okay, guys.
Haytham, you are about to ask a question.
Thank you.
Okay, so any other question for Dr. Shabir? Okay, just before concluding the session, today we're supposed to have a journal club, but unfortunately the presenter apologized for presenting for today for some family issues. So again, I would like to emphasize that future presenters for next week and the week after should be ready to fill up any gap due to any emergency. So for next week and the week after, please be ready with your presentation so we can utilize our time efficiently, because this is our protected time, so we have to use it in a proper way. And in regards for the presentations, each presentation should be in at least 1 hour. So if you finish your presentation early, you can support that with questions, MCQs, scenarios, just to give the topic, to go thoroughly through the topic so we can have the maximum benefit out of it. So for next week presenters, please try to contact consultants from today. And if you have any issue, you can contact me anytime so we can help. Thank you very much, and see you next week.
Thank you, guys.
السلام عليكم.
وعليكم السلام.
لابد فيصل يديكم خبر. اليوم كنا بنناقش في المجلس العلمي حاجة على الفورماتيف اسسمنت. حيفضل السايت مفتوح كمان يومين لين يوم الأحد. الناس هذول اللي ما شاركوا إلى الآن ويحبوا يشاركوا. يلا بالتوفيق إن شاء الله. عنده أي أسئلة بالنسبة لله formative assessment؟ السلام عليكم.